In this video, we will be discussing about preeclampsia. In our previous video, we have seen about an overall outline of hypertensive disorders of pregnancy, the introduction and classification. So here in this video, we will see about preeclampsia. Preeclampsia is nothing but there is increase in blood pressure associated with proteinuria. This proteinuria is significant when it is more than or equal to 300 milligrams per day, that is in 24-hour urine sample. So the incidence of preeclampsia is around 8% to 10%. First, let's see the risk factors. The risk factors for developing preeclampsia are: first is nulliparous women. It is more common in first pregnancy. Next is family history and past history in previous pregnancy. Next, it is also more common in multiple pregnancy, molar pregnancy, polyhydramnios, next when the woman has other comorbidities like obesity, diabetes mellitus, pre-existing hypertension or renal diseases. Next, age more than 35 years. So these are all some of the important risk factors of preeclampsia, and one important point to note is that smoking has a protective effect for preeclampsia. This is because while smoking there is release of nitrous oxide. So this nitric oxide is one of the important vasodilators. So thereby it has a protective effect for preeclampsia. Next, coming to the pathogenesis. So normally there is trophoblastic invasion which occurs in two waves, primary wave and secondary wave. The primary wave occurs at around 12 to 14 weeks of gestation, whereas the secondary wave of trophoblastic invasion occurs at around 16 weeks. So here in primary wave of trophoblastic invasion, the invasion takes place up to the endometrium, and in secondary wave the trophoblastic invasion occurs up to the myometrium, under the endometrium. So it goes deeper. So in case of normal pregnancy, this extravillous trophoblastic invasion there is extravillous trophoblastic invasion which takes place on the spiral arteries, making them high flow and low resistance. So there is increased blood supply to the placenta and thereby to the fetus. Whereas in case of preeclampsia, The important pathology is there occurs vasoconstriction. Let's see how. So in case of preeclampsia, there is defective secondary wave of trophoblastic invasion So, because of this, there is narrowing of spiral arteries, thereby decreasing the blood flow to the intervillous space, leading to fetal hypoxia due to uteroplacental insufficiency. So, this fetal hypoxia causes increased vasoconstriction and decreased vasodilation. This increased vasoconstriction is because of certain factors which are released like endoglin and soluble tyrosine kinase like receptor 1. These factors get increased, thereby leading to vasoconstriction, whereas there is decreased vasodilation due to decreased vascular endothelial growth factor, placental growth factor and decreased nitric oxide. And also because of fetal hypoxia, there is release of certain inflammatory mediators into the maternal circulation which cause capillary breakdown and thereby produce edema in the mother. So, this is the pathogenesis of preeclampsia. The important step is there is defective secondary wave of trophoblastic invasion which causes narrowing of spiral arteries, thereby causing fetal hypoxia, causing increased vasoconstriction. Next, the clinical features of preeclampsia. There is hypertension, as we all know. Next, there is proteinuria and edema which are due to increased vascular permeability. Next, there is coagulopathy because of abnormal expression of procoagulants. Next, there is headache. This headache occurs because of cerebral vasospasm. There is blurring of vision and scotoma due to retinal vasoconstriction and occipital ischemia. There is pulmonary edema due to pulmonary vasoconstriction and there is epigastric pain which is because of the formation of splinter hemorrhages below the liver capsule which leads to formation of hematoma, because of which there is stretching of Glissen's capsule which is the liver capsule, and this produces epigastric pain. Also there is oliguria because of renal insufficiency due to renal vessels vasoconstriction. So these are all the clinical features of preeclampsia. And also the reasons behind each of the clinical feature. Next, coming to the investigations. So apart from routine investigations done during pregnancy, the additional investigations to find out the severity of preeclampsia include urine examination for urine albumin. more than or equal to 300 milligram in 24-hour urine sample is considered significant. Next, we perform complete blood count to look for hemoglobin, PCV, WBCs, total count and differential count, platelet count. So the platelet count less than 1 lakh per millimeter cube indicates severe disease. Next, we do blood urea, uric acid and serum creatinine levels. Next, we perform liver function tests. This is done when HELLP syndrome is suspected. What is HELLP syndrome? HELLP syndrome, the H in HELLP syndrome stands for hemolysis, EL for elevated liver enzymes and LP for low platelet count. So in LFT, there is increase in all liver enzymes like AST, ALT, ALP, all are increased, and also bilirubin level increases. Next, coagulation profile is also done when the HELLP syndrome is suspected. Here we look for bleeding time, clotting time, prothrombin time, activated partial thromboplastin time and INR. Next, we do fundus examination. To check for any fundal changes suggestive of hypertensive retinopathy. Optical fundus examination. Lastly, coming to the management. Management is different for mild preeclampsia and for severe preeclampsia. For mild preeclampsia, we advise additional rest, salt, restricted diet, then regular monitoring of mother, BP is measured twice a day and urine every day. Next, we check for fetal well-being using biophysical profile. If the gestational age is less than 37 weeks and if the blood pressure settles or there is insignificant proteinuria, we can advise the patient to go home and to report to hospital if she has any warning signs. If the gestational age is more than 37 weeks, after ensuring fetal lung maturity, labor is induced. This is management of mild preeclampsia. Coming to the management of severe preeclampsia, first main important thing is that the patient is hospitalized. There is no outpatient treatment for severe preeclampsia. And the same way as in mild preeclampsia, we advise rest and diet restriction to the patient. And in addition, they require antihypertensive therapy. When the BP is more than 160/110 millimeters of mercury. And our aim is to keep the diastolic blood pressure between 90 to 100 millimeters of mercury. This is to prevent maternal complications like cerebral hemorrhage. So the drugs used for antihypertensive therapy, currently the drug of choice is labetalol, which is both alpha and beta blocker, given 100 milligrams twice a day, and additional drugs which can be added are nifedipine, which is a calcium channel blocker, given 10 mg orally. An important point is nifedipine should not be given sublingually. Nifedipine should never be given sublingually. And in case of hypertensive emergency, we give IV labetalol, the dose starting from 20 milligram, then we can increase it to 40 milligram, then to 80 milligram, and we can give another 80 milligrams. So maximum of 220 milligram IV can be given. So this is the management. Next, if the woman is responding to treatment or if it does not worsen, then the pregnancy is continued till 36 or 37 weeks of gestation under strict vigilance. If it worsens or symptoms of imminent eclampsia develop, the pregnancy is immediately terminated irrespective of the gestational age. And also prophylactic magnesium sulfate is given in patients with severe preeclampsia. So lastly, coming to the management principles of severe preeclampsia. First, we admit the patient, then we evaluate the mother and fetus. We give magnesium sulfate prophylactically, antihypertensives if the BP is more than 160/110 millimeters of mercury. If the gestational age is less than 24 weeks, we give magnesium sulfate and terminate the pregnancy. If it is more than or equal to 34 weeks, we give magnesium sulfate and induce labor, deliver the baby. If the gestational age is between 24 to 34 weeks, then we give corticosteroid therapy for lung maturity, and we give expectant management with the aim of reaching 34 weeks. So this corticosteroid therapy, we give betamethasone 12 milligram in 2 doses intramuscularly 24 hours apart. So during the expectant management, delivery within 48 hours is indicated if there is presence of any of the following: delivery within 48 hours is indicated during expectant management if any of the following is present. One is uncontrolled severe hypertension, or if there is eclampsia, pulmonary edema, signs of imminent eclampsia, oliguria, which does not resolve with fluid intake, or there is thrombocytopenia with platelet count less than 1 lakh per millimeter cube, and there is deterioration of renal function. In all these cases, during expectant management, delivery within 2 days is indicated. A word about imminent eclampsia. So, imminent eclampsia, there is rapid deterioration in an established case of preeclampsia. This is called as imminent eclampsia, and here there are symptoms like the danger signs of preeclampsia, which include restlessness, severe headache, vomiting, epigastric pain, visual disturbances, pulmonary edema. So, these are very much marked in these cases, and the management of imminent eclampsia is same as that of managing eclampsia. This is all in this video. We will see about eclampsia in the next video. Thank you.